So now it comes to the outcomes. And here we focused, this study focused a lot, it paid a lot of attention to heterogeneity and treatment effects. So in this diagram we have basically how well you do on treatment A. In the study we're going to talk about later, it's going to be atypicals versus typical antipsychotics for the schizophrenia population in Medicaid. But in this picture we essentially have on the, it's not coming through here, but to the right of the 45-degree line here are points of patients who respond better on the first treatment than they do on the second treatment. So the second treatment is y-axis, first treatment is how well you respond on the first treatment, the y-axis how well you respond on the second. A given point tells you how well you respond on both treatments. The points to the right are people who are responding better to the first treatment. The points to the left of 45-degree line are those responding worse to the first treatment. Now this has important implications. This is virtually all classes you can think of. You have these kind of patterns of people responding well or not on certain treatments. The problem with CR as currently envisioned, where we essentially say, is this product working better than that product, is that the winner in the CR is losers for some patients. So if the winner, let's say the treatment mean, let's say we ran a randomized clinical trial and the treatment mean was to the right of this 45-degree line, meaning on average people responded better to the first treatment than they responded to the second treatment, then presumably everyone worse off, everyone to the left of the 45-degree line, i.e. the people who responded better on the loser in the CR, would be harmed by now payers responding by better coverage for the winner in the CR, or high reimbursement, lower co-pays, what have you. And the general issue is that CR as currently envisioned is product-specific policies when treatment effects are patient-specific. It's not so much we argue about, is it the blue versus red pill that's the best one, ignoring political colors, but for whom does the red versus blue pill work? That's really what you should be trying to find out. Okay. As envisioned now, that's not necessarily the case. We want to find out which treatment works best. That's, I think, is a misleading way of going in and structuring CR studies. But that's the standard way when we run a randomized clinical trial, such as we do in the FDA context, to essentially getting a one-size-fits-all that's going to be harmful. And the important thing is here, essentially, is the dependence across treatments. And this is going to come in later. It's very, very important. What do I mean by that? Suppose you didn't respond well on the first line of therapy. Then a randomized clinical trial doesn't tell us anything about whether we should continue with the second-line treatment. What you need to know whether you should continue with the second-line treatment is, conditional on having failed first-line treatment, how well are you going to do on second-line? That's not what a clinical trial is set up to answer many times. Clinical trial tells you about the average treatment effect without using any information that you failed on previous therapies. And that's going to be very, very important for CR, because if the CR declares a given device a winner and another one a loser, it may be that the people who basically don't respond for the winner may well respond for the loser. And that's negative dependence in treatment effects. That is to say, if you don't do well on one, you do well on another. That's a negative correlation between how well you do across treatments. If you have positive, perfectly positive correlation, that says if you fail first line, we know you're going to fail second line. That would be completely different implications for whether you should continue treatment, because we learn now that you're not responding on one treatment. And if you have positive dependence in treatment effects, you're going to know that you're not going to respond to the other, perhaps because everyone who's frail don't respond to anything. So when you have these negative dependence in particular, you get these not just indeterminate effects of CR on spending, like I talked about, but many times indeterminate effects of CR on health outcomes, because you're shutting down losers, or basically some part of the population for which the CR declared a loser are now getting hurt by CR policy. So we brought this to the data for one of the most important drug classes in Medicaid, which is for the indication of schizophrenia. And there's been a huge debate in that area whether first or second line generation drugs are more effective. And there was a big study commissioned to try to answer that question called the CATIE trial. Schizophrenia is, like I said, an important class in Medicaid. There were two main lines of treatments, typical and atypical antipsychotics. The first generation were called typicals, the second generation atypicals. What's interesting here is, comparing to the result of CATIE, is that before the CATIE trial, and somewhat after, but not as much, 90% of the market was second generation drugs. Then the CATIE trial came in. It's a National Institute of Mental Health sponsored study. And it started, I think, in '99, came out in 2005, with the following main conclusion: that first generation and second generation antipsychotics don't have any real significant differences in effectiveness, despite that 90% of the market is paying a premium for the second generation drugs. So this is a very strong statement about how poorly markets work. 90% of the market is paying extra money for something that's equally effective. So we actually had the trial. We took the CATIE trial data, and here's sort of the mimicking version of some of the heterogeneity in responses of patients across the treatments in the trial. So the main question we considered was, should Medicaid cut coverage for the least cost-effective treatments in the CATIE trial? Atypicals, meaning second-generation drugs. That's sort of the first-line question that people were interested in, and some states have responded in that way, in terms of at least PEA requirements for second-generation treatments. And this is basically, from the discussion had before, this is basically asking the question, if CR studies, such as the CATIE trial, drives payers, such as Medicaid, to respond in their coverage or reimbursement policy based on the evidence, this is a sort of a classic case we could continue or could consider to look at what would be the implications of that.